I appreciate the opportunity to be here tonight and talk to this group and talk to the group online about pediatric sports medicine and sports injuries, and kind of talk about some important topics and tie that into why we're doing what we're doing here at Children's and what we've built around here at Children's, both children's physicians and within the hospital and children's specialty physicians. We've built kind of an integrated model. First of all, why do we have kids participating in sports? In my mind, we're really looking for three things. Number one, kind of healthy lifestyle promotion. We're trying to get them to get engaged and become interested in doing physical activity that can promote lifelong health. And the other important factors, learning to work on a team, just being part of a group and knowing your role and being able to engage in again, good teamwork and have that play into the third topic, which is sportsmanship and learning how to win and lose gracefully. I think all of those aspects are important in socialization and just growing. Now, the risks in sports, and especially in young people in sports, primarily surround three areas. One is acute injuries, which are usually the more serious catastrophic injuries. The second being overuse, which, for instance, in baseball, when you have pitchers who pitch year-round and, again, keep throwing and throwing and throwing as they're growing and developing, then there's some specific injury patterns that we tend to see. And the third being is overall overtraining, where young people will develop just true fatigue from, again, doing too much for too long. When a question is, what does F equals ma? When I go back to Newton's second law on going back to your high school physics, when we talk about acute injury, the impact of the force as kids get bigger, and especially the high school boys tend to weigh more, then as they get bigger and their mass increases, the amount of force that they can imply onto their opponent increases too, and then the risk of injury goes way up. I wanted to start talking about concussion, and specifically I wanted to talk about a few just kind of case reports and describe why we're doing what we're doing here at Children's. For the Chicago Bears fans in the crowd, Dave Duerson was, again, one of the best Bears of all time, two-time All-American at Notre Dame, Super Bowl champion in 1985, four-time Pro Bowler, 11 years in the NFL, and here's Dave's suicide note. See that my brain is given to the NFL's brain bank. Dave killed himself in such a way to preserve his brain for future study because he knew that things just weren't right. He also had a very strong feeling that the way he felt and the depression and the anxiety that he had been feeling as he became near the end of his life was caused by football. And what we found is that Dave was right. Dave had what we call chronic traumatic encephalopathy, or CTE. CTE is something that comes only from repeated blows to the brain over and over and over again. Sometimes they're serious, often they're relatively minor, but it's that repetitive blow which causes deposits of a specific protein that doctors call tau proteins, and those are the dark stained areas on the slide. But the only way we get those protein depositions are from, again, repeated trauma and repeated blows. Now, when we see these proteins developing in the brain, they typically come with just what I described in Dave: depression, anxiety, mood changes, and in Dave's case, depression to the point where he committed suicide. This is Owen Thomas. good-looking young redhead, co-captain of the 2010 University of Pennsylvania football team. Began playing football when he was 9 years old. He committed suicide at the age of 21 in college. Owen had no history of concussion, no history of mental illness, and he only mentioned to his parents that he was doing poorly in 2 classes the day before he hung himself in his off-campus apartment. And at autopsy, Owen also had CTE, again from that kind of chronic repeated injury to the brain. Eric Pelly. Eric is was an 18-year-old young man, actually died from complications of concussion. Again, began playing football at an early age, about the same age that Owen Thomas did. And even at age 18, Eric had evidence of CTE at his brain as well. So here's my only mind-numbing slide on the physiology of concussions, and take you back to your high school chemistry and biology. And what we know about the physiology or the biology of concussions mainly comes from animal models. But what we've learned is that there's this basic kind of chaotic metabolic crisis that lasts for just under a week, where you have potassium ions flying out of the cells, calcium ions flying in, the sodium-potassium pump is in complete disarray, energy in production of the brain drops along with blood flow to the brain. But the important thing to remember about this is no cell death occurs as long as there's not another impact to the head while this is going on. And that's one of the keys that we've really taken to help guide us in our management of concussions in young people. Who's at risk for concussions? Number one, people who've had them before, and even 1 or 2 prior concussions increases your risk significantly. We also look at, along with the number of concussions, how severe were they in the past and how long do their symptoms last. Interestingly, when we compare sports where the rules are the same, such as basketball, ice hockey, soccer, the rates of injuries in girls and women for concussion is higher in young ladies than young men. And our management of concussion sometimes gets clouded if people have mood disorders like depression, ADHD, learning disorders, or if they suffer from migraine headaches. And of course, an aggressive or reckless style of play is going to increase that person's risk of concussion as well as their opponents. Other risk factors, poor technique. There are obviously specific sports that we tend to see concussions in more often. For instance, football, hockey, rugby, soccer, basketball are a lot more common than, say, golf and tennis. I think it's important to have the helmet of any helmeted sport fixed and fitted to the head. I'll bring back Newton's second law again for F equals ma. And this is important when somebody's receiving the hit in a contact sport. The weight of a head in an adolescent is about 15 or 16 pounds. And if the impact is there and the person doesn't have time to prepare and brace for it, the entire force of that impact gets absorbed by the 15-pound head. If someone can anticipate the hit coming and they have a moment just to be able to tense up, especially tense good strong neck muscles, then the impact is spread out through the weight of the entire body instead of all of that impact being absorbed by the head. And hydration plays a role. I clearly think that we're going to find out that there's a genetic role in concussions, and as with anything in life, luck certainly plays a role. Key points to think about and just to know about concussions, and there have been some myths and theories that have been bannered about over the years. It's important to have a helmet that fits properly. There is no thing as a concussion-proof helmet. There are companies out there that are trying to market concussion-resistant helmets that is based on some data that is not universally accepted by the sports medicine community. And in my opinion, we are just nowhere close to having the technology available to be able to disperse the forces to the head, which can cause a concussion. People have tried other things like add-ons where you get these great big, extra foam rubber add-on pieces to, say, football helmets to help dissipate those forces. In my opinion, that just creates a bigger target, and there's no data out there to show that those decrease the chance of developing a concussion. And the light-up chin straps where if somebody has an impact to the head, this big red light goes up on the chin strap, and then you're supposed to think about pulling individual players out. Great in theory. In practice, in my mind, it's just not practical, simply because there's no set threshold of force which we have found that can cause a concussion. It may be below the impact point where that chin strap will light up. It may be well above it. And I think really we need to look at individual players and symptoms. Question? Great question. The question is there a proper way for a parent to know that the helmet is fitted? In football, in general, you should be able to see 2 finger widths above the eyebrow, and same in hockey. That's one of the reasons I use this picture on this slide. In football, the ear holes should match up with the opening to the ear, and that's there for 2 reasons. Number 1, for helmet fitting. Number 2, if the holes line up with the ears, young people can hear better. And the helmet should come down and cover the base of the skull and the back of the neck. And probably most importantly is once the helmet's on and the chin strap is fitted, it should basically be an extension of the head. So what we don't want to see is a helmet that's strapped on, and if an adult grabs hold of the face masks and moves that helmet around, the head should move with the helmet because it's essentially one unit. If you've got a young person standing in front of you and you move the helmet, but the kid stays looking straight ahead, then that helmet just doesn't fit. So it's kind of all of that. And that's with football. And those same principles apply for other helmeted sports such as lacrosse and ice hockey too. So, did that answer your question?
It does.
Okay, thank you. You bet. The other point that I wanted to bring is mouth guards. Years ago, the thought was out there that if young people wore mouth guards and they got hit on the chin, then those forces could be dispersed by the mouth guard and your chances of developing a concussion would decrease. Great in theory. When it got tested, it really makes no difference. So from a concussion standpoint, mouth guards really are not effective prevention. Now, please don't walk out of here and say Moffitt said that we don't need to wear mouth guards. Mouth guards are very effective at preventing dental injuries, and I still encourage them, but just don't leave thinking that mouth guards can prevent concussions. So what happens on site if we're suspicious? If, again, you're a parent or a coach and a player goes down and you're concerned about, again, concussion. If the head's injured, one of the first things I always worry about is the neck too. Is the cervical spine been injured as well? And it's important to, again, make sure there's no tenderness. And a good rule of thumb for parents who are acting as coaches is ask the question on the field. Can you get up? Are you ready to get up? And when a young person can get up under their own power and get to the side, they're probably fine. If they can't get up, then, and I've been in that situation where the kids are physically unable to get up, the game stops, you don't move them, call 911, and then the individual's moved off safely. Because I guarantee the outcome of that game or the schedule of that field or court running on time doesn't matter when it comes to especially the safety of the head and neck of a child. There are some specific tools that are out there. I'll show one in a moment called the Pocket Concussion Recognition Tool. It was put together by an international group called the Concussion and Sport Group. The CDC has another one online at their website, cdc.gov, which is called Heads Up Concussion. And again, is just another nice tool. Both are online and are free. The bottom line, if a young person is suspected of having a concussion, they're removed from play, they're done for that day, and they're not left alone. So as a coach, you hand that child directly off to their parents, and again, there's no same-day return to play. And the current standard is that all young people with suspected concussions are evaluated by a licensed health professional with specific expertise. And in Nebraska, that is a physician, either an MD or a DO, a physician's assistant, or a nurse practitioner. Here's an outline of the pocket concussion recognition tool, again, that you can get online. And it gives some kind of verbal cues and talks about what to look for, as well as some of the common symptoms and some basic screening questions that can be asked, such as, what venue are we at today, which half is it, who scored last in this game, etc. And kind of goes through some red flags. But when we look at overall symptoms, again, the brain is the thinking part of our body. So when it becomes injured, we don't think clearly. People talk about fuzzy thoughts or, again, just kind of cloudy thinking. They have difficulty concentrating. They feel slow, and they have difficulty learning new information. And it's that difficulty learning new information and balance are probably two of the big key symptoms that we often see. Headaches, again, are probably the most common symptom. And then we see other things a little less commonly: blurry vision, nausea, dizziness, sensitivity to light or noise. And then over time, people develop some emotional issues, such as being more irritable or sad or nervous or anxious. There are several old symptoms or classifications of concussions where we used to grade things as 1, 2, or 3, and then based on the grading, develop some return to guideline recommendations for people and families. And there are 3 old grading systems that have some history behind them. Bottom line is, know that these are old and they're not used anymore. Kind of our new line of thinking, again, as we grade concussions, is basically either be simple or complex. And then we figure out kind of our return to play based on the individual symptoms, not just plugged into a grade 1, 2, 3 grid. And it's important to know too that LOC, or loss of consciousness, really doesn't help us out with determining the severity of concussion. 90% of concussions have no loss of consciousness and can be quite severe without LOC. Concussions are mainly a pediatric problem. The developing brain, and what we've learned over the last year or two, obviously there's a big difference between the brain of a 12-year-old, a 14-year-old, a 16-year-old, and an 18-year-old. And how that brain is impacted at different points in development clearly plays a role on the injury itself and recovery. Now, historically, football helmets, people have become frustrated because they're worried about, again, let's build a helmet that can prevent concussions. And I touched on that a bit ago, but the football helmet was currently designed really in the late 60s and around 1970. And it was designed mainly to prevent skull fractures, and it's done a fantastic job of that. We've really had in high school, college, and pro sports, pro football, we've had no skull fractures in a properly helmeted individual since 1970. And I think that statistic's incredible. When we look at hematomas or bleeding on the brain, those have decreased by 80%. So we've, again, had some just dramatic improvements in injuries to the head with our current helmet design, but we still need to make another giant leap in engineering to prevent concussions. Now, the timing of this discussion tonight and what we're doing at Children's really came out of a need due to kind of just overall increased concussion awareness between parents and coaches and the lay public, doctors ourselves, athletic trainers who are the ones actually in the trenches, especially at the high school level. The recent NFL proposed settlement to the Players Association to help resolve some of their long-term, the players' long-term issues with concussions. And here in Nebraska, LB 260, which was signed into law and took effect last summer. And what what LB 260 says is that every kid and every parent and every coach in any organized sport in the state, whether you pay a fee, if it's volunteer, whether you make a profit, whether you lose money, if it's an organized sport, this law applies. And what it says is any player who exhibits any sign of concussion must be removed from practice and can't return to play that day. Also, they can't return to play until they've been seen by, again, an MD, DO, physician's assistant, nurse practitioner. And then the parent, athlete, and coach education is all part of that. So when a concussion happens, what do we do about it? And again, acutely, simple, no return to play, and it can't be one of those, I think you might have a concussion, but you look okay a little while later, so I'm going to let you back in. It's no. If there's any suspicion, they're done. And that player not be left alone. Again, we need to be evaluated by a physician or other professional. And this is my opinion. I don't have a lot of data to back this up, but I tend to see kids do better with a day or two of solid physical and cognitive rest. So being out of school for a couple of days, I think helps. And then we work on a return to play protocol, which is very supervised and stepwise. And we'll go through that in just a moment. But again, a good rule of thumb is just when in doubt, sit them out, because the risk isn't worth it. The testing, again, SCAT3 is from that International Concussion in Sports group that I touched on earlier. And they've given doctors and healthcare professionals some really good tools, and the lay public some good tools, such as that pocket concussion recognition tool. Impact is a commercial tool, which the concept and the utility is very helpful, where ideally anybody in a contact sport takes a baseline test before the season begins, and you have to do everybody because you don't know who's going to get hurt on the back end. And then when somebody is injured, you've got a baseline test that you can follow up with later and see if somebody's returned back to their baseline function regarding memory, reaction time, and again, a few other things. Impact has I think a good competitor and another product called CogSport, which is very similar. Impact tends to be used more widely in this part of the country. There's a tool called the Acute Concussion Evaluation, or ACE. I think it's a very useful tool, but I think the SCAT3 has improved upon that. And then for people who have really complex or long-term symptoms, we do some real formal neuropsychological testing. And again, that's done by specialists in the field. Here at Children's, we're mainly using a combination of the SCAT3 for 13 years old and up. There's a child version that works well for ages 5 to 12, as well as impact testing kind of when appropriate. And I think both of the tools are good tools in the toolbox. My frustration with some people regarding either of them, especially impact, is did I pass or fail my concussion test? And if I passed, I can go back. If I failed, I can't. And again, the impact and SCAT3 are just tools, and it's still important for me to look at the overall big picture and address symptoms, recovery in the classroom, and recovery on the field as well before we put these young people back into collision sports. Imaging, important for families to realize. Doctors have gotten to the point where the old days of somebody gets their head injured, They show up in the emergency room, they go through the CT scanner, the CT scan says negative, so go see your doctor. Well, by definition, any concussion will have a normal CT or MRI. So as doctors, if our suspicion is concussion and not bleeding on the brain, the CT scan does a great job of helping us sort out those people. But if the doctor doesn't think there's bleeding on the brain, that the person is concussed instead of that, then what we don't want is a CT scan, because if I can avoid blasting a developing child's brain with a whole bunch of extra radiation that they didn't need, that would be my preference. So, return to play. What do we do? Step one, again, early on there's no grading and there's no physical activity other than just normal activities of daily living, walking around the house, and waiting until someone becomes completely symptom-free. When they feel like they're back to normal, and then I may apply some of the testing in this process too, but when we feel like the concussion symptoms are gone, then we start, again, kind of this graded program of exertion. And in general, for most, again, older teenagers and people in the early 20s, they become symptom-free in about a week with their first concussion, second concussion about 2 weeks. For younger teenagers, you can pretty much double the time and double their return to play time. And again, it's all due to the developing brain. So again, we rest completely until we're symptom-free. Then light aerobic exercise, such as jogging for 20 minutes. And what we're looking to see is, do these symptoms come back? If the headache, the dizziness, the fuzziness of thought, if all of that comes back, then again, you stop. No more running. Try it again. I usually wait a day or two and see if they can tolerate it again. And once we can tolerate that step, then we progress on to more sport-specific things, such as skating in hockey or running in football, and then kind of progressively adding in some resistance training. Again, same thing. If they become symptomatic, we back off, try it again later, within a day or two. If they can tolerate it, the next day we add non-contact training drills. And if they can tolerate that, that's the point where I like to see people again in clinic and can repeat my evaluation. For me, this is the ideal point to repeat the impact testing to make sure we're back to baseline. And if everything's appropriate at that point, I like to see a full contact practice. If that can be tolerated, then they can return to play. The important thing is each of these steps takes a day, and in younger people, especially younger teenagers, you can almost double or triple the time, where it should take at least 2 to 3 days to go through each step. And again, these are kind of standard national and international guides. So if I'm working with a high school and I have a high school football player who sustains a concussion on Friday night, and we rest and we go through this, there's no way that individual is going to be ready to play the following Friday night, because there's no way we can get to a full contact practice that's going to occur before that next game. So as a general rule, most high school football players will be out minimum of 2 weeks, and some longer depending on their symptoms. And again, if any symptoms occur, we drop back and reattempt. Now the complex concussions, the ones that last longer than a week or so, again, the guidelines are those are managed by doctors with specific expertise in concussion, and those people with specific expertise are neurosurgeons. And just in general, I don't think neurosurgeons want to see concussions because they can't operate on them and fix them, and that's what neurosurgeons do. Neurologists, who are quite qualified, but it typically takes weeks to months to get in to see a neurologist, or sports medicine physicians who, just by nature of what we do, we get people in pretty quickly. And it's also important that when we're talking about return to play and working through the progression, that we're symptom-free without medication. You can't be taking Tylenol and Motrin to suppress all your symptoms and then try and go through the progression. That's cheating. And again, in return to play, I like to look at kind of my total concussion history. Again, how severe were the previous concussions? I was mentioning to a group last week, I had one young man years ago when I worked in professional hockey who was a Harvard grad. Again, played hockey for Harvard, then played mainly in the minor leagues, I think did a short stint in the NHL, but had been hit so many times, he could literally stand in the locker room, shake his head quickly, and induce concussion symptoms. And it was at that point where I think he and all of us around him finally realized that it was time that he stopped professional hockey and maybe use that Harvard education, and now he's in business and I think doing successfully in the East Coast. We've kind of lost touch. But again, the severity of the previous concussion, what does it take to bring on the symptoms, the time between injuries. If someone's had 3 concussions, it's a big deal to me if that's 3 within 6 months, or has it been 3 spread out over the last 10 years, separated by 5 years each? You know, those are 2 completely different conversations. A whole new concept in concussion management really over the last year plus, and this is a huge area of exploding information, and we're hoping to get more information on this over the next few weeks at the national level. But the analogy I give families in the office is if you're a basketball player and you sprain your ankle and I ask you right away to run up and down the basketball court, what's going to happen? Your ankle's going to swell up and it's going to hurt. Well, for concussions, it's kind of the same thing. If you injure your brain and I send you back to work on algebra and geometry, and by the way, we're going to cover French and history, and all of a sudden, there's no stamina left, and again, all those concussion symptoms get worse. So what do we need to do for our school-age kids? For most people, I think taking a day or 2 off school is ideal. There are very few kids that really need to take more than that. But I do think during that recovery, shortening the school day is helpful. Allowing breaks when kids are studying, you know, say math for instance, and they feel those concussion symptoms coming on, that they have a chance to take a break, let those symptoms calm down, and then kind of get back at it. No test taking. It's kind of like asking that basketball player, you know, not to run sprints right away, because we're asking to assess how well does the brain work after we've injured the brain, and by doing that in a concussed brain, we're going to cause all those concussion symptoms to come back. The player's going to do poorly, or the student is going to do poorly, and you've created more of an injury by bringing out all these symptoms and making the whole process last longer, and you've created poor test scores as well. So we build in increased time to complete work, and then when we're at a point where we can test, then I ask the schools not to put all the tests back on the same day, spread those out and allow for increased time in the individual tests as well. So switching from concussions and talking about, again, other sports, I like to include baseball, and mainly because if you look at the shoulder and the elbow, the human arm was not designed for the sport of baseball. I've included this slide because it's one of my favorite slides in any medical textbook. I've never seen anybody's look on the face like this, but it gives you that same mechanism that we just saw with the pitching mechanism, where the arm gets pulled back and the shoulder becomes unstable towards the front. And we see this in throwing athletes who do it chronically, or very commonly in football too, where somebody goes in for a tackle and the arm gets pulled back into this position, and then the front of the shoulder dislocates forward. In Little League, again, there's an entity called Little League shoulder, which is a stress-induced fracture, again, caused by mainly overuse, And we see this in that early teenage years. Again, these are kids who are throwing over and over and over again. We see it a lot more commonly in sidearm pitching or in people who throw with what's called a dropped elbow, where the elbows drop below the shoulder. And on x-ray, again, this is what Little League shoulder looks like. That's the growth plate right there between the arrows, and that space is much wider than it should be. And you get those distraction or pulling forces across that growth plate from, again, repeated throwing. Little leaguer's elbow, again, same kind of mechanism from throwing too much. Again, occurs on the medial or inside part of the elbow. And again, pitch counts have become kind of a key part of what I call baseball medicine. And we count pitches per game a lot, but it's more important to count pitches in a season. And it's that kind of chronic overuse, big picture. How many pitches has this individual thrown? And again, we tend to see it more with sliders and curveballs, although the data has become a little bit more shaky on those two. The treatment for this is exactly what families don't want to hear, and it's rest. And it typically takes 6 to 12 weeks of not throwing to recover from Little Leaguer's elbow. So again, these are overuse injuries, so the treatment for any overuse injury is to not use it. And this is not something you can play through. Yes, question?
To softball pitchers. Baseball and softball, are they both?
Yep, the question is baseball and softball pitching. Softball pitching is much, much kinder on the shoulder and elbow than baseball. Yeah, baseball, throwing a baseball or pitching a baseball is, I love the sport, I enjoy it, but it's not something that the shoulder was designed to do. The shoulder is much better designed to pitch a softball. And we don't see these types of injuries nearly as much. In the knee, there's a whole bunch of stuff that can happen within the knee. The kind of inside knee joint, we have cartilage, we have ligaments that cross in the middle, the anterior and posterior cruciate ligaments. There are the outside collateral ligaments, excuse me. And again, any of those can be injured. The outside ligaments, they heal beautifully on their own. They typically take about 6 weeks to heal. The inside ligaments, the cruciate ligaments, are one of the few ligaments in the body that when they tear, they don't heal on their own. They're not going to grow back. And once those are torn, typically within 5 to 10 years, around 95% of people by 10 years will develop arthritis in the knee. So not something you want in a 15-year-old athlete who by the time they're 25 is going to have an old man's arthritic knee. I included this slide because I like it. It's from the same artist and same textbook. But again, it shows the other main problem with the front of the knee. So not the structures inside the middle of the knee, but regarding the quad or quadricep and the kneecap. And the kneecap can sometimes partially dislocate or completely dislocate. Both are quite painful, and again, we treat both differently. And growing people can have a host of problems within the knee itself, usually involving this part of the knee, where the growth plate below the knee can become sore and inflamed. There's one within the kneecap. The tendon that connects the two can become inflamed. And again, we treat all of those a little bit differently. Ankle injuries, the textbooks say 95%. I would say it's closer to 98, 99% of ankle injuries occur this way, where the foot goes down and gets rolled in. And I think about it as, you think about a basketball player going up for a rebound and coming down on someone else's foot. And the ligaments on the outside of the ankle get stretched first. And if they get stretched hard enough, they can tear. And they always tear in order. And like everything else in life, the more stuff that gets stretched and torn, there are 3 main structures out there, then the greater your risk of having more long-term complications, and it makes the whole recovery process last longer. Less commonly, we'll see the ankle turn in, and again, thankfully, we see this only, like I said, 1% to 2% of the time, but it's much, much more serious. Those outside ankle ligaments, it takes time to heal, but they heal nicely without surgery. Kind of like the ligaments on the inside of the knee, the ligament on the inside part of the ankle doesn't heal well and often has an associated fracture with it. And these are a much bigger deal and often require surgery. Treatment for most sports injuries, the old acronym was ICE, ice compression elevation. And of course, over the years, people have had to, one at a time, add new letters. The most recent that I've seen is PRICES, where you can talk about protection, relative rest, ice compression, elevation, and support. And often we'll use NSAIDs, or nonsteroidal anti-inflammatory medicines such as naproxen or ibuprofen, and physical therapy is quite useful. But of all of these, and especially in my days when I was in professional hockey, the most important one for me was compression. Loved professional hockey, loved the players I was with, because my career was tied to their recovery, and so was theirs, but a big part was mine. I didn't trust any of them, and compression was a big part of it, and a big part of recovery. And I knew that early on, if I could keep swelling out of an acutely injured either joint or muscle, I could cut down recovery time on the back end by days to even weeks. So again, of all of the PRICES acronym, compression is the most important to me. I've included this just to illustrate that just like the shoulder was not designed for baseball, I don't think the spine was designed for gymnastics. And again, I love gymnastics. It's, again, a beautiful athletic event. However, we see some specific, both acute and overuse injuries regarding the spine. In general pediatrics, regarding pediatric sports medicine, I think this is probably the most important thing we do. It's that pre-participation or pre-season sports physical. What I get most frustrated with are these mass physicals where we try to run through 200 kids over an hour or two in a morning or an afternoon, and everybody donates $10 and that money goes to the athletic department. They typically come down to, if you have a pulse, you can play. And in my opinion, the best physical is still back in the office with the primary care doctor who knows that family, knows that child, has seen them grow up, and not only can address sports, but again, kind of the whole host of other issues. And as part of this, we're not just screening for musculoskeletal problems, shoulder, knee, ankle, hip. We're screening for cardiac disease. There are, again, rare but a specific number of diseases where when people exercise, they can develop cardiac arrest and drop dead and have a sudden cardiac event. Obviously, there are signs for that, and some we pick up on physical exam, most by history. And I think it's important to, again, have somebody who knows the patient, knows the family. And a lot of times the young person doesn't even know the family history. We really need to get it from the parents. And that's what this documents and program is designed to do. In addition to the cardiac issues, we're also screening for asthma, eating disorders, and really, again, a whole host of other things. What are we doing differently at Children's? Again, I work with my colleagues in sports medicine and the adult side of the world, but adult medicine and pediatric medicine is different. Children are not small adults, and I think our knowledge of physical growth and development is important. Like we've talked about, the growth and development of the brain is important, and we're really trying to focus on the non-surgical problems. And most of the things that kids are injured with, thankfully, don't need surgery and don't necessarily need the skills of a surgeon, but need the skills of somebody with expertise in this area. And that's what we're trying to bring to the table. And we're targeting the younger age group, 8 and 9 to really through junior high and then high school as well. Important things for me, for parents and coaches to remember. Remember the kids are looking up to you. Remember you're a role model. Remember that they will remember your behavior a lot more than they will remember the score of the game. And thankfully, most injuries in kids are minor. And we don't see, again, serious things in the big picture very often. But when they happen, I like to think we're prepared here at Children's to handle those. And I think we've got questions.
The first question is from a mom. She has a 13-year-old son. He had slipped down some stairs last winter, hit the back of his head, and had a minor concussion. He plays football. Mom is concerned about him playing football right now. Any concern there?
The question goes to a 13-year-old who sustained a concussion last winter after hitting their head, and now they're playing football again. I'm assuming that that they are completely back to normal, and back to normal with activity, and back to normal in school by now. I hope they are. Only, again, it's about 1% who would still be struggling with symptoms for this long. But even by having one concussion, and especially at a younger age like 13, they're at probably a 3 to 5-fold increased risk of having another one in the future. Now, does that mean 100%? No, but again, everything increases their risk. For football, one of the important things for me is for young people to realize it's a safe sport as long as they don't lead with their head. And it's that head-to-head contact or that helmet-to-helmet contact, either, again, significant hits or less forceful hits, but repetitive over time, that tend to give us, again, concern and moments to pause. Okay.
In reference to the shoulder injuries, should you stretch your child's shoulder then before they participate?
Question revolves around stretching and helping an individual stretch their shoulder. I think flexibility is important in any sport, but especially baseball. I think warm-up's important, and I do think stretching's important. And it's important to stretch through the whole range of motion. In other words, for shoulder, again, straight up, coming out this way, and for throwing, stretching back into kind of that throwing or cocking position. But it's important to stretch to the point where somebody can feel the stretch, but that doesn't cause pain. Because again, stretching should never be painful. It should be viewed more as a warming up and, the part that people often forget, kind of a cooling down activity as well. And I don't think there are any other questions here. So thank you everybody for coming. I appreciate your time and attention today. And if there's ever anything I can do to help, again, please feel free to let me know.